before we dive into this with three national experts, I want to kick this off with a little introduction by a patient, Betsabeth Para, a recent patient who can share for us her experience with our new cardio-oncology program.
I started my cardiac issues back in 2009, and it was a big symbol of just getting a checkup with a primary doctor, and he noticed I had a heart murmur and referred me to a cardiologist just to get it checked, nothing major. And it turns out that I ended up having to have my left valve removed. 2013, I had a cardiac arrest while I was in Zumba class. So that was just further complications, further heart issues that I was having. Once I met Dr. Mookadam and the Cardio-Oncology team, he emphasized that he believed this was a correlation, all of my cardiac issues that I were having was a correlation from the lymphoma I had back in 2008. Just kind of, I had a feeling something was, somehow correlated. Luckily, I went through chemo, radiation, and I was fine and never came back. But almost exactly a year later, is when I started having my cardiac issues. I think I was going on 2 years of feeling these symptoms where I just, either my heart was having issues or my valve needed replaced. And he knew that I needed attention, like immediate attention. And I didn't really have to explain much as far as my oncology issue. He kind of looked at it in my chart and he just made everything make sense to me. I think everything that I had felt before, he just confirmed it. And I felt like, oh my God, I'm not crazy. So it was really nice. When I first met him, it was a big impact. I actually felt like, okay, I'm gonna be taken care of, I'm gonna be fine. Since then, I have had my heart valve replaced. I had open heart surgery in December 2021, and now I'm feeling great. I follow up with them several times. In addition to Dr. Mookadam and his team, I was able to get referred to a great surgeon, and I had great care. I think we're all set, and this is going to be my cardiologist from here on out. So the first time I met him it was very life-changing for me.
And we're back.
Such a great story, and we always talk about the Sophia that Banner cares for, and I think to have Ms. Para just talk about her experience really encapsulates the type of expertise that we're so proud of with this cardio-oncology program. And obviously behind any program, you have to have stars. And the first star I'm going to introduce is Farouk Mookadam, who we were lucky enough to recruit from the world famous Mayo Clinic. He's a professor at Mayo Clinic and a professor here at the University of Arizona College of Medicine in Phoenix. And he's the director of our cardio-oncology program and really has this vision of elevating the standard of care, elevating the patient experience. So without further ado, Farouk, please take it away.
Thank you, Dr. Tung. So our cardio-oncology program is about 2 years old now. I have been involved in cardio-oncology for almost a decade. We were one of the first to introduce this concept. At the time we started a cardio-oncology clinic at Mayo, we were one of 4 centers across the globe. And our goal is to serve the cancer patients and to serve the oncologists. With that said, I'd like to share a few slides with you about what cardio-oncology entails. So we talk about this concept of shared risk. We know that the heart is injured when it is exposed to certain risk factors. This is not novel. They are very common. Lack of exercise or a sedentary lifestyle, use of tobacco, diabetes, elevated cholesterol, processed foods, etc. Well, these are the very same risk factors that actually induce the beginnings of cancer. So it's not unexpected then that an individual who may have cardiovascular disease may at some point develop cancer. And it is equally not unexpected that somebody with cancer may have extant cardiovascular disease. More important, some of the cancer treatments may cause cardiac injury to a varying degree. Oftentimes, radiation to the chest may cause injury to the heart. Hence, the specialty of cardio-oncology, where there is strong collaboration between the cardiologist and the oncologist who place the needs of the patient first. This collaborative effort then improves the quality and safety of patient care. So this article, which is about 10 years old now, talks about the competing risk in patients with breast cancer who eventually succumb to cardiovascular disease. This brought to my attention the need for this specialty called cardio-oncology. The comorbidities between cancer and cardiovascular disease can enhance or increase risks to the patient. The cardiovascular risk factors may actually be an impediment to optimal cancer treatment, or the cancer treatments may bring out, resurface, or introduce added cardiovascular risk factors, which complicates care of the cardiac patient. So tight communication between the oncologist and the cardiologist is paramount. That's why we need this practice integration. The safety in patients with cancer is an emerging clinical issue. Cancer patients now survive, and living with cancer is almost living with a chronic disease. We have patients that I share with Dr. Paul, whom you'll hear from shortly, that may have cancer for 10 or 15 years on ongoing maintenance cancer treatments, and we do the surveillance on these individuals. If there is an issue with their heart, we then correct and fix the heart and trade them back over to the oncologist as we partner for the safety and quality and well-being of these individuals. There are innumerable cancer agents that are novel, that follow novel pathways and mechanisms of killing cancer cells. Many of these will have cardiotoxic effects. So this is a dynamic and moving target, and many high-quality cardiologists no longer feel comfortable looking after these complex patients with the new information that's available and the new cancer agents that they need to keep up with, hence the need for a cardio-oncology specialist. We would like to improve not only the quality, but also longevity among cancer patients. To give you an example, among hematologic malignancies, the commonest cause of death has nothing to do with cancer. It's actually cardiovascular disease, and that's where we come into play. The similarity between the risk factors that cause cancer and the risk factors that cause cardiovascular disease in terms of incidence, risk factors, and pathogenesis are then clear with this little introduction that I've provided. This is a slide that shows in white individuals who have cardiac dysfunction. So the ejection fraction is the pumping action of the heart, and if it falls below 55%, it's considered abnormal, or there's an impairment of the heart. Now, if you look among those individuals whose heart function is down, but because of the cancer, they complain more about the cancer-related symptoms rather than the heart symptoms, only 50 to 60% of them, or less than 40 to 50% of them are receiving any medications that protect the heart, and maybe 50% of them are referred on to a cardiologist. As soon as the patients have specific cardiac symptoms, then a higher number are offered the medications that can protect or heal the heart, or are referred to a cardiologist. Even then, it's just above 80%. So there's 20 to 25% of individuals that are not getting optimal care. So this brings about the concept of value in healthcare. And those of you in business who know this equation, value is the quality provided over the cost of that healthcare. And the role and goal of the cardio-oncology clinic, which is underpinned by imaging and clinical decision-making and partnership between the patient, the oncologist, and the cardiologist, is what provides that added value. At Banner and MD Anderson, we aim to improve that value, we aim to improve the quality, and we aim to improve the safety whilst prolonging the life as well as improving the quality of care. So this is a New England paper that came up some time ago, and it has a beautiful quote that I would like to share with you. In any field, improving performance and accountability depends on having a shared goal, a goal that unites the interests and activities of all stakeholders, the patients, their families, the oncologists, the cardiologists, and the healthcare team. What do we do in cardio-oncology? Early detection, detecting the problem early, and then early intervention. This slide speaks to that fact in a powerful manner. This shows in the yellow bars that if you detect cardiac injury within 1 to 2 months, and the patient has an intervention or treatment, 2/3 of those individuals, you can recover the heart to normal. If there's any delay in referring these patients to a cardio-oncology specialty center, let's say 2 to 4 months, we can still improve the heart to normal in 54% of the patients. You can see if you delay after 6 or 7 months, then the opportunity to restore the heart to its complete function is markedly reduced and is almost zero. We still do try, and we have many medications that we can introduce. Some of these are common medications, and they have to be tailored to the individual at the time that we see them. So this is personalized and individualized care. What we do currently, if you look at this slide on your far right, once a cancer patient has a cardiovascular event, they then visit a cardiologist. That cardiologist may not necessarily be a cardio-oncologist, so the added value of benefit to them may not be optimal. In the cardio-oncology clinic, we have a robust imaging center that depends on quality, and Dr. Sam Unzek will speak to you on that in a minute. So once they have an event, we see them, but we're hoping to slide down this slope and come to what's called secondary prevention. With the techniques and novel technology through echocardiographic imaging of the heart, we can detect early damage, increase our surveillance, and intervene at an earlier point before there's overt damage. What we are hopeful for, with your help and with the vision from the institutions and from my colleagues on this panel, is get to primary prevention. Who are these individuals? Who are these patients that may be more susceptible to cardiac injury? How can we identify them? And I think we're on the cusp at the moment of putting together identifiable risk factors that can identify these individuals. And then we see them upfront in a collaborative manner, integrated with the oncologist to identify these individuals and either treat them upfront or arrange for closer surveillance so we can prevent cancer treatment-related cardiac injury and carry the patient safely and effectively through their journey. With that.
And thank you, Farouk, because it really goes to show how medicine, being at the forefront, we should be very forward-thinking and think about preemptive therapy, precognition, predicting when someone is at elevated risk, rather than just following up all the potential sequelae or the complications of something. I mean, cancer as a disease has had so many new innovations we're going to get to in terms of treating it. And that's why Farouk is saying many people are living with cancer rather than dying of cancer. So it's becoming a chronic condition. But then so many of the therapies that we deliver that are breakthroughs do have potential cardiac complications. And it makes so much sense to have a cardiologist there that knows about all the different cancer regimens and all the cancer complications, because I think patients often get lost between going from specialist to specialist. Oh, my cancer doctor says this, my cardiologist says this, and who's going to talk? But when you get a cardio-oncologist that's embedded within the cancer center, then we're transforming the way the healthcare is being delivered. Farouk, it's very novel, right, to actually be embedded within the cancer center at MD Anderson. Isn't that right?
That is correct. So many of the places will have a cardiac center separate from the cancer center. And we're hoping to overcome that and have a cardio-oncology center within the cancer center. So here at Banner and MD Anderson, we run a clinic 1 day a week on the Phoenix campus, and we run a clinic 2 days a week at the MD Anderson Gateway campus. So we're embedded within. We still have miles to go, much to build before we're completely integrated. And through informational sessions like these, we're hoping to get there within a year or two, so that we become a nationally and internationally recognized, fully integrated, fully embedded cardio-oncology program, as you so nicely summarized, Dr. Tung. Thank you.
So fantastic. And before we move over to Dr. David Paul, we wanted you to hear from one of his patients. Take it away.
I was 59. I went for just a basic mammo, and they found in my right breast, and they said at the time they thought it was cancer. And I was totally shocked, to say the least. In May of 2010, this all started. And then in 2015, it went to my lung. 2016, it went to my lymph node. In 2017, it went to my liver. Then in 2019, I did chemo. I hadn't heard of the cardiology-oncology at all. In fact, it's been kind of a joke. You know, I go to a specialist, and he's a cardio-oncologist. I mean, his name is very hard to pronounce, and I call him Dr. M at home. But my heart issue was all of a sudden one day, I was doing what Dr. Paul wanted me to do, an echo every 3 months. All of a sudden, my heart rate, and I'm going to say it was like 65, which is good, dropped down to 50. That's not good. So that's when he called in the doctor to look at my heart, and he did all this and to find out that it was really where on the scale I really was, and I was fine. I can't explain how thorough I really felt that he did. I mean, he knows what my history was with regard to my other echoes and all the other key ingredients, because I've got a long list of things over 12 years. But it was just an experience that I had never had before. Those are the kind of doctors I think that should be out there. I wouldn't go anywhere else. I wouldn't. There's no reason to. When you got the best, stick with it. I don't think it's just doctors giving you pills or anything like that. I think it's a lot to do with your mental attitude as well. You know, I don't have cancer. Cancer has me. That's a big difference. I want to live. And there's a difference between living and living. And I live my life. I've got things to do. We're going on another cruise in July. We're going to Aruba, and then we're going to the Panama Canal. I mean, and by the way, I've signed up for tap lessons in my spare time. So I do have a lot going on. So I don't have time to die. Definitely don't have time to die.
That is such a wonderful and inspiring clip there, Dr. Paul. And those are words to live by for all of us, regardless of cancer or heart disease. Fantastic. Dr. David Paul is the physician executive of Banner University MD Anderson Cancer Center. And it's so amazing to have a world famous MD Anderson, and then in collaboration with Banner University, and Dr. Paul oversees that. And he's the co-director of the Cardio-Oncology Clinic. So we've got the cancer doctor and the heart doctor. But when I first came here, David, we met and we talked about getting this off the ground and really taking this across the finish line. And it was just your support saying, we got to do this. This is the right thing. This is the best for patients. And Dr. David Paul has been such a champion for this program. So congratulations on the kickstart. And David, please take it away.
Oh, thank you, Dr. Tung. Well, it's been a pleasure being a part of this collaboration. At MD Anderson, we're all about integrating care. And so when I think of a patient, and as our team thinks about patients, we're always thinking about all of their needs. I think as a patient who walks into a cancer center like ours, I think they have certain expectations. They have expectations about a lot of things, but in terms of treatment, I think it's very easy for them to think about chemotherapy, radiation therapy, and surgery as kind of the typical X's and O's. But after a short while spending time with us, they come to realize how many more needs they have and how many more of those needs we're taking care of, in the cancer center, from nutrition to counseling to supportive care to social work. There's so many things that spin, around the needs of a cancer patient, and increasingly foremost of those needs is cardio-oncology. So I think that patients have come to understand that we can provide care in an integrated way, in a collaborative way, in one location where they're not trying to, find the things that they need all over town. They're finding it at a world-class location associated with a world-class organization. And it's just a joy. What I like to say is surrounding patients. I just want them to feel surrounded by all these different people from different specialties who care for them. Kay is a great example of the things that we've highlighted already in terms of patients that are living with cancer. And she told you 2010. This is something you might not expect in association with breast cancer. But increasingly, the treatments are improving. We're finding ways to maintain their health. And as a consequence of doing that, unfortunately, there can be consequences, and in her case, with her heart. So it's a double-edged sword. But what Dr. Mookadam has taught us is that as medical oncologists, we're used to being in surveillance for heart disease. We know the type of drugs that are more prone to doing that. What we need to be more in tune with, and all of us as specialists in cancer, whether it's surgery, all of the different specialists, is that we need to identify these patients earlier on. We need to identify those patients who have risk factors. They don't have their heart disease yet. They have risk factors, and we're now bringing them into an arena where we're adding risk factors intentionally, but for the purpose, for the betterment of their cancer. But to bring Dr. Mookadam and his team in even earlier is our goal, in helping, through our collaboration, recognize those patients who are at risk that we might not have thought of previous to this.
Well, that's fantastic, David. And part of this, it sounds easier, right? Because you've been at this for a long time.
Right.
It sounds easier said than done. And this is amazing to get it off the ground. But by surrounding the patient, and for our viewers that are thinking, okay, well, that's obviously best for the patient. There's so many challenges to integrating, and particularly when you have to go across different buildings and across different structures.
Right.
What is your future state of the true integration? What does that program look like as we now are piloting and have been successful?
Well, we opened our center in June 2019, just on the first floor of this 3-story building. And very quickly, we filled up that first floor space with, again, the X's and O's of oncology: surgery, medical oncology, radiation, diagnostic radiology, palliative/supportive care, counseling. I mean, all the things that we needed to get started in Fusion. And just this past April, we were able to finish the rest of the building, and we opened in April of this year. We've been in collaboration with Dr. Mookadam and his team, as he said, for the last 2 years, but now we have the space in the second floor, to now do this. And not so, we talk about a virtual world these last 2 years, and we've had this virtual clinic cooperating, with our patients and coming to his building, and now we have the opportunity in our own building for him to see the patients. And I've found, since having come to Banner MD Anderson 4 years, to have my experts literally on my elbows is so much. There's so much faster integration, so much faster collaboration with other specialists in taking care of someone than waiting for a phone call that you've left with someone. Literally to be in the same hallways and figuring out the care for these patients has been great.
Love it. Well, our third expert here is Dr. Sam Unzek. and he's the director of cardiac imaging for our entire division of cardiology and one of our leaders in all non-invasive imaging. He actually won Mentor of the Year for teaching and his involvement with both residency and our cardiology fellows. So that's deeply important to our mission, our tripartite mission of obviously teaching, research, and then patient care. So Sam is going to talk to us about the value of just cardiac ultrasound or echocardiography.
Thank you very much, Dr. Tung. I'm going to say save the best for last. So there's going to be a lot of what I call, and Dr. Mookadam as well, because he's an echocardiographer, eye candy. So be prepared. So I have no disclosures, and honestly, it's important because imaging, this early detection that Dr. Mookadam really refers to, as well as Dr. Paul, is my mission. And the only way to do this is by having a good imaging lab. Chemotherapy and immunotherapy have really done significant, a good job in trying to increment the survival in these patients, but they also come sometimes with a price. And anthracyclines especially, as well as some other chemotherapy and immunotherapies, may affect the heart. And as you can see in this echocardiogram, the heart function is normal, and it may end up being altered like in this image. So it's very important not only to detect it early, but also once you have the affection of the ventricle not being able to function well, we need therapy for it. We use several modalities in cardio-oncology, but I'm going to focus on this talk only on echocardiography because it actually checks all these boxes. It's a very simple test, and it's a test that can actually detect a lot of the things that we're looking for. We base most of our clinical decisions on two very basic parameters, ejection fraction as well as strain imaging. This is remember, the heart is a 3D structure, but conventionally we use 2D imaging in a lot of these labs that are out there. With 2D imaging, you're able to cut virtually the heart in several planes, and you're able to see, as you can see in this echocardiogram, some of the walls, the valves, and then cut in a different plane and see a very different aspect of the heart. Then we're able to measure around that cavity of that ventricle and then come up with a ejection fraction. Now, being this a 3D structure, but measuring in 2D, you're gonna have some assumptions, geometric assumptions. So the technology has evolved that now we're able to do 3D imaging based on some of the new technology. And this has really upped our game because there's no assumptions anymore. We'll know the true ejection fraction, and this has been verified with other imaging modalities. This is basically just a simple echocardiogram that we did today that was able to calculate the ejection fraction very nicely, as you can see here. But ejection fraction is not the end-all be-all. There are subtle changes that may happen even before the ejection fraction drops. And this is where basically strain imaging becomes very important. Strain imaging is a little bit more complicated, but to simplify it, as you can see, the heart it may lengthen, may twist, may shorten, and this is easily measurable with the echocardiogram through different modalities, one of them being tissue Doppler, another one being a speckle tracking. It's a very complex way of doing it, but the most common one that we use of all these movements is a longitudinal strain. Now, this is a great example where you can see that all the segments are represented in different colors, and you're able to see exactly how well they're functioning over time. Now, strain may be able to detect early changes even before the ejection fraction changes. And these changes not only are diagnosed, or this strain is not only helpful in diagnosing, but also in prognostic value. those patients who have an abnormal strain actually end up having worse outcomes than those who have preserved strain, showing in this image. This is just a great example of a patient that saw Dr. Mookadam, had an echocardiogram done as an outpatient in a different facility. We reviewed the images, and it was probably, the technique wasn't that great. Saw Dr. Mookadam at BUMCP, and then ended up having an ejection fraction of 60%. This was life-changing because now the patient was able to obtain the chemotherapy and continue to use that same chemotherapy agent that Dr. Paul recommends that will be most effective.
Excellent. Thank you, Sam. So Dr. Unzek gave us a great intro to a cardiology fellowship lecture. If you guys were cardiologists or learning about this really important diagnostic tool, echocardiography, this is nothing more than an ultrasound. It's non-invasive with gel, like looking at a baby and being able to see the images of how the heart is functioning. We can see gross abnormalities when it really doesn't squeeze. But what Dr. Unzek is talking about with strain is a more sophisticated technology of being able to detect very subtle early warning signs that there's going to be dysfunction. And that's this whole element, like Minority Report, of precog or precognition, of being able to get a window and saying, okay, let's get to this patient before there's a catastrophe. But it's also really important because many patients with bad heart disease will get chemotherapy withheld because maybe they don't have enough reserve. But if we have newer therapies for those patients to improve their heart function, then they can go on to get the cancer therapy they deserve. And I think that's where also being able to develop a cardio-oncology program is fertile grounds to support the academic mission, university-based, which is with clinical research. Because research is really where the future of medicine will be. And if we're on the forefront of that, then we should be able to bring protocols and new treatments to patients that they wouldn't ordinarily have access to in the community. And I think that's definitely our mission when we talk about treating these patients. So hopefully that gives a great window into how we do diagnostic imaging, what we're looking for in the whole program. And now we want to open it up to you, the audience, for questions and answers. And it's all open, it's all fair game. This is for you. One of the questions, and thank you for being brave for the first question, is cardio-oncology only appropriate for those with breast cancer?
So that's a great question. Breast cancer is one of the commonest cancers, and so the majority of the patients that we see likely come from the breast cancer center. However, any and all cancers that are being treated either with chemotherapy or the more novel antibody or immune therapies, or something called TKI, tyrosine kinase inhibitors or VEGF inhibitors, all have an element of cardiotoxicity. When we talk about cardiotoxicity or cardiac injury, the most important element that will occur with some of these agents is the ejection fraction going down. And with the early detection that Dr. Unzek pointed out so nicely, we're able to measure. But other cardiovascular side effects occur as well, such as arrhythmia. There's something called QT prolongation, with which you will be familiar with, Dr. Tung, that can portend sometimes near lethal arrhythmias. And there are also cancer treatments, apart from the cancer itself, that increases the risk of blood clots in these individuals. So the whole gamut of patients with a whole gamut and diverse types of cancers, with all of the different treatment strategies, radiation, chemo, immune, or antibody type therapies, all of the patients that we look after.
And myocarditis, that word came out in the lay press with COVID vaccination and everything. But I think what you're talking about with injury is cardiac inflammation, myocarditis, which can then have a downward spiral and then lead to dysfunction of the heart. Dr. Paul?
You know, as we go back to Dr. Unzek's diagram with the arrows that really pierced my heart, frankly, because those are all some of my favorite treatments. in response to the question, two of those group of agents were things that we primarily use in breast cancer, but the other three, taxotere, sunitinib, carfilzomib, one of those, is very commonly used in multiple myeloma, others for renal cell. Another, taxotere, is a breast cancer drug, but we use it across a spectrum of diseases. So truly, all patients with cancer and with the expansion of different cancer therapies, we as medical oncologists need to be aware of their risks.
And the other services that are provided by Cardio-Oncology is also rapid expedition of being able to get to surgery. So sometimes you might not get a chemotherapeutic agent that's going to be toxic or potentially toxic to the heart, but maybe you need brain cancer surgery. Maybe you need cancer for ovarian cancer, but you have a cardiac problem and you need to be cleared or stratified or have your risk assessed. Well, the best person to take care of that would be a cardio-oncologist as well.
You're absolutely right, Dr. Tung. About, I would say, a quarter, 1 in 4 of the patients that come into the cardio-oncology clinic is part of a pre-operative assessment or pre-operative evaluation. Some of them are extremely challenging. They've had cardiovascular disease maybe for years, they've had a heart attack, maybe they have high blood pressure for many years, but the cardiac function is not normal. And these individuals whose heart function is not normal now have to go through major surgery, if it's lung cancer or esophageal cancer, or abdominal cancer. They may be older patients, and so their risk of undergoing general anesthesia and all of the effects of anesthesia, of being quote unquote under while the surgeon is doing the operation, poses a risk. And it also stresses the heart. So our job as part of the cardio-oncology seamless care is, before any chemotherapy is given, if you identify an individual with cardiac risk, we see them, we optimize them, we hand the patient to the surgeon and try to minimize, lower, or mitigate the risk so that the surgery is completed safely. This is part of the quality equation we discussed. The patient and the families are happy and comfortable, the surgeon is happy and comfortable, the oncologist is happy, and then subsequent to that, any cancer treatments can be provided. The comprehensive manner in which we handle the patient affords us not only the perioperative event, but the ongoing care. And many of these patients who are cancer survivors will need lifelong follow-up through a cardio-oncology center, because cancer, as you know, as you see, with the survivorship increasing in number, has become a chronic disease as well.
And obviously the risk for a cardiovascular complication is highly dependent, to be part of the educational part, on the regimen, and the specific types of therapies. But there was a question in the audience about, is there a hierarchy? Like there's chemotherapy, and obviously they're not created equally, the immunotherapies, but what about immunotherapies versus traditional chemotherapy versus radiation? Is there a hierarchy of risk? They all have unique complications.
Absolutely, and in our calculation, which we use when we see the patient, we measure 3 things. The first one is the patient. Who is the patient? Are they young or old? Does the patient have extant cardiovascular risk factors? The common ones: hypertension, diabetes, tobacco use, history of tobacco, elevated cholesterols. Has this patient had a history of heart failure? Has the patient had any form of cardiac injury? The second component we take into account is the cancer treatments. What cancer treatments has this patient been exposed to in the past? So anthracyclines are a good example, well known since 1975, when van der Hoff first described cardiac injury and cardiotoxicity from anthracyclines. Oncologists are now fantastic about minimizing, based on the individual's body weight, the amount of anthracyclines that are given. But for every 100 milligrams per meter squared dosage, the risk goes up. The next element we look at are any of the cancers in the chest, such as lymphoma, lung cancer, esophageal cancer. Will they be getting radiation? Breast cancer, is it on the left side? They'll be getting radiation on the left side, which may expose the heart. The radiation oncologists are fantastic in mitigating that with breathing in to take the breast away from the heart, with having the patient prone and shooting the radiation beam so it minimizes cardiac exposure and injury. And on the right side, there's much less injury. So we ask all of these as we gather data. And then we put all of this together and create a risk score for the patient. Based on that, we identify a care plan and we identify a surveillance plan. So everything is very methodical, very meticulous, and based on what is current best evidence for those individuals. This is what gives us value. Without the input of Dr. Unzek, who has what we call a level 3 high quality echocardiographic lab, we cannot do this. Having an echo done at a facility, which sometimes the patients find a little bit of an encumbrance, because they may live in the West Valley or in the East Valley, they may be out of state, and they would like to get their echocardiogram imaging at another facility. It just does not give us the definition of information that we require to make these critical decisions for their safety and for the benefit of the oncologist, whether we hold the chemo, whether we delay the chemo, whether we reduce the dose, or whether we're gung-ho with great confidence. So all of these elements put together is the recipe that makes for high quality cardio-oncology service.
I think that response really illustrates the highly specialized nature of the clinical decision making that has to occur with the integration of technology, good clinical judgment, and then obviously different specialties. This is why cardio-oncology really wasn't the biggest thing to talk about as a specialty probably outside the last decade, but now it's had this birth, and even the Journal of American College of Cardiology has its own whole cardio-oncology journal that's dedicated to the treatment of cancer therapies in heart disease patients and vice versa. So it really highlights the specialized nature. People keep the questions coming because I think we're getting a logjam already, so we'll keep moving along. There was already a question about how do I get an appointment, Dr. Mookadam and Dr. Paul? And obviously we were hoping that we have 5 Dr. Mookadams, but this is the pilot, and 5 Dr. Pauls. But how does someone get an appointment?
So your oncologist will know to contact us. If not, you can create an awareness and say, we heard there's a cardio-oncology program at MD Anderson or at the university, and then make those contacts.
And that's the downtown Phoenix campus.
That's the downtown Phoenix campus. We do the same at the Gateway MD Anderson campus. Dr. Paul may speak to other ways in which you can get to visit with us. I think we'll try to post information on the online video how to contact cardio-oncology.
Is there does this program exist in Tucson yet, our sister campus?
Not as robust as we have down here in Phoenix, but the goal is to have this banner system-wide and MD Anderson system-wide. Dr. Paul may know a little more, but Houston was one of the first centers in the world to have a cardio-oncology center. Dr. Paul?
Yeah, so in Houston, there are 30 Dr. Mookadams in supporting the very large cancer center in downtown Houston. To give you some idea of how important cardio-oncology is to MD Anderson.
Well, so we've got a ways to go, but what a successful pilot. So 1 down, and then we have an additional Dr. Kalia, who's a heart failure specialist, who's also very interested in cardio-oncology, and we're hoping to recruit more. So our plan is obviously a very rapid growth plan dictated by the needs of the patient. If more patients need it, and Dr. Mookadam's already booked out for a couple months, which I know is already the case, then we're going to need a lot more and get to 30. There was another question about, should every patient before they undergo chemotherapy have a quick look at with a cardiologist like Dr. Unzek or Dr. Mookadam?
So there are patients who may be considered low risk, and I think in a couple of years we will have a nice algorithm of what's considered low risk, and those patients need not see a cardio-oncologist. There are among that group, and we've seen a couple of low risk. When we say low risk, we mean low risk for cardiac injury with the cancer treatments that may read in the mainstream media or through webinars such as this, feel that they may be vulnerable as far as cardiac injury goes, and they too can make an appointment. But those low risk ones generally do not need to see us. The intermediate risk, the oncologists are very good at getting the initial echocardiogram and an ECG, and if they see any abnormalities, they send it onto the cardio-oncology clinic. And of course, there's the high-risk patients. We already know that women age 65 or more overweight, even by a mild degree, history of tobacco use, any cardiac history, arrhythmia, heart failure, angina, coronary disease, stent, bypass, any of those. If you have 2 or more of those risk factors, you are at risk for developing cardiac injury. And those are the individuals we like to see up front. Those are the individuals that the oncologist can get serial echo and ECG. If the patient either has symptoms or any of the tests become abnormal, those are the individuals that benefit most from the cardio-oncology integrative practice.
And I think if we do our job, the future state is to look at a large healthcare system like Banner, that we roll this out, we prospectively validate it. This is where some of the outcomes research goes. We can figure out which type of phenotypes need this sooner than others and who doesn't need it. And part of the job of cardiologists is always risk stratification. Same for cancer doctors. Is who's at the highest risk, who's not, and how do we mitigate that risk? A question for Sam. Can you get an echo in Tucson? I think you can. But what an echo is, the gateway for all of cardiology in terms of imaging. But what should a patient expect when they're getting an echo? What is that experience like?
So honestly, it's a very simple study. You should expect probably about an hour, at least through our own protocol. About 45% of it will be imaging. The other percentage would be probably the preparation, the machine, the post-processing imaging that occurs after it. But it's a very simple test. It's done laying down. They use a small little probe, which is about this size, that they put jelly on. Don't worry, it's a warm jelly, so you won't be cold. And they put it in different positions in the chest, and they start gathering information. After that, it honestly takes about 30 minutes or so to be able to be done. And then after that, then the physician will read it, will measure it, and then create a report and send it to Dr. Mookadam and Dr. Paul. So it's a very simple procedure. No, it doesn't hurt. It does not produce radiation. These are ultrasound waves that do not produce any long-standing issues.
And there's 2 parts of it. There's the technical component, which is the cold gel, and then having great sonographers,
Warm gel.
Cold or warm gel, depending on. And then we have an advanced cardiac sonographer who's also educating our staff to deliver the highest level of acquisition. And then there's the interpretation skill led by Dr. Unzek, and there's different levels. And then Dr. Unzek was able to achieve international accreditation for Echo Lab, which is really distinctive at Banner University compared to all the other banners. So, and then obviously elevating Echo at Gateway. So our job is to obviously raise the bar for the entire Banner Health system. There was a question about philanthropy and what do we need to grow more? This is a pilot, it's successful. Dr. Mookadam's booked. Where would an investment in cardio-oncology be best kind of assigned to? And what are the areas that we need for further growth to ensure success?
So that's a great question. The needs of the patient need to be met in a timely fashion, so on time, with high quality and precision. The information needs to be readily available to the cancer surgeons, the oncologists, the hematologists, and that can be achieved if the cardio-oncology center is embedded within the cancer center or within the oncology center. That would be optimal. If a breast cancer patient sees Dr. Paul down the hall in room 3, and Dr. Paul feels there's a need for the cardiologist to see the patient, then Dr. Mookadam or any of our cardio-oncologists should walk down the hall and visit with the patient, or the patient can be escorted to the cardio-oncology center area of the cancer building. When we see the patient and the patient needs any type of testing, whether it's an ECG or an echocardiogram with the high fidelity and input that Dr. Unzek mentions, and I'll take a second to emphasize, all echoes are not equal, as simple as they are. If you're not getting a high level 3D EF and strain imaging, then the quality of the data input for our assessment and clinical decision making is less than optimal. You need high quality echo If they need any form of stress testing, then it's all done on the same floor, in the same building, in a seamless manner. The patient's comfortable in the cancer center. And that would be the goal. That would be the investment that philanthropists need to look towards. Banner has a good center within the foundation for philanthropy, and I think looking towards that component of Banner University, seeing what the needs are, the amounts are, and the investment that would be required to create this high quality that benefits the patients, the physicians, the providers that are involved in that patient care, and of course the community.
Dr. Paul, where would you put the investments right now to our young and growing program?
Well, as Dr. Mookadam has pointed out, I mean, we've gotten off to a great start downtown, at our center and in Gateway in Gilbert, and I think just further expanding the services of those two areas can give us a great reach to the valley. But if any of us have lived here for any length of time, I mean, it's 60 plus miles, from one end to the next. So we would love to be able to expand these services, in other parts of the valley, and again bring that convenience to the patient, but not just any echo. I mean, bring the greatest medical expertise as well as the technical expertise to other parts of the valley. And I think, we talked earlier about research. I mean, research requires a lot of infrastructure in terms of the nurses, the data collection, all of the folks that involved in creating that effort is also a costly endeavor. And so I think as this program grows and it gets bigger, I mean, we're going to be hopefully teaching others, the lessons learned and how to identify patients and what we're looking for, and all of those things I think would be great for Phoenix.
And there are some new translational research projects that have been made famous by Joe Wu at Stanford called iPSCs, induced pluripotent stem cells, which can actually take someone's blood, actually maybe not have the disease, expose it to chemotherapy, and see if there's a toxicity in a petri dish without even exposing the human to it. And that's called induced pluripotent stem cell work. And that's really exciting. So I think on the translational side, there's so much opportunity to even boost research in terms of investments. I would also say that it takes beyond a village to keep this program going. And obviously, while Dr. Mookadam might get 15 or 30 minutes, or Dr. Paul with a patient, it's all the patient care coordination around it to make sure that Sophia or Miss Para is not lost in this, because she needs an echo, and then what's the result of it and how does that go? So I think that's where a lot of the resources also need to go to make sure that we continue keeping that patient up front and keep them in the know, keep them coordinated, and keep it timely. There's a couple medical questions that are quick ones, and I'll just take the liberty of addressing those. One of them is atrial fibrillation a manifestation of carcinoma or cancer? Not typically. Atrial fibrillation is so present, it can even affect 1 in 5 Americans if we all live long enough. So cancer itself is not usually the underlying cause of atrial fibrillation. It's a lot of the comorbidities that Mookadam's been discussing that are risk factors for cancer as well as heart disease, like obesity, the metabolic syndrome, type 2 diabetes, insulin resistance, the type of diet that we have, the sedentary lifestyles that all of us unfortunately succumb to with our daily pressures. So I think all of that is not usually a risk factor for atrial fibrillation. Other question was, how do you get a 3D echo? And Sam can talk a little bit about that. It's imaging of a 3D structure, and we take slices. You look at a plane or a window of imaging, but there's even newer sophisticated 4D methods to be able to look inside and try to look at the structures more in a 3-dimensional view.
Absolutely.
But I think obviously any program like this, which is so based on imaging, could use advancements with the latest technologies.
Yes.
Right, there's always a newer version of an echo machine. There's something called PET MRI, which is maybe a $1 or $2 million scanner, but would it be able to give us the ability to look at ultra high level structural information as well as metabolic information on a heart that could be vulnerable or under attack with chemotherapy? And those are things that we don't currently have yet.
Yeah, there's a lot of technologies that I didn't, because of time, but there's different technology like PET MRI, like even MRI itself, that are very important, that look at very different mechanisms of disease and mechanisms that might be affected by the chemotherapy, that but the truly working horse is the echo. But there's also other key imaging modalities that I wasn't able to talk because of the time, that are also crucial. We have a lot of them, but we also don't have, the other part.
The latest and greatest
The
of
latest
them.
and
There's something
greatest,
called PET
exactly.
scanning, which is used to be able to screen cancer and see how extensive the cancer may have spread. But we're also starting to look at PET scanning for inflammation in the heart, as a lot of these therapies can cause myocarditis, which is what we've been talking about, cardiac injury. So to close, I know we only have about 5 minutes left. Let's go around the room. What got you interested in cardio-oncology? The people want to know your story. What seduced you to develop this passion, Farouk?
So I would say about 12 or 13 years ago, I was called to the operating room at the Mayo Clinic and asked to do an intraoperative transesophageal echocardiogram. And we have what's called the blood-brain barrier. So the patient is asleep and anesthetized on the bed in front, and then anesthesia has the anesthetic machine here, and then there's a sterile sheet between the patient and the anesthetic staff. And so we do the transesophageal echocardiogram from this end. And so we call the surgical end the blood side, and we call the cognitive side here the brain side. So that's the blood-brain barrier. So we did the TEE, and upon completion of the TEE, the cardiac surgeon wanted to know where they should put this left ventricular assist device. So it's kind of an artificial heart, you might say, that helps a very poor heart pump better. And I looked over this blood-brain barrier at the patient once I'd given the surgeon the information, and there was a young woman who was in her 30s. And because they called me up urgently, I hadn't reviewed the data, except they wanted an urgent LVAD. Upon completion of the study and giving information to the surgeon, I went to the corner of the operating room, opened the chart and reviewed the chart. And it was a devastating story. 38-year-old lady, 2 kids, trying to work, was admitted the night before through the emergency room. 8 years earlier, she was exposed to anthracycline, and this was the result. She could not get a heart transplant because she had to have certain criteria to meet that. She was so far gone that the medications couldn't work, and she was now dependent on this. So she had to quit her job, and I said to myself, I said, this is preventable. And that's how I got into cardio-oncology.
I love it. And I know we want to keep on time. For me, my father was diagnosed with colon cancer at a very young age and survived it and was treated at the world famous Cleveland Clinic. So cancer was something that rang true to our family, and we were so grateful for the cancer care. And when you really look at the condition of where we are in America, with heart disease being the #1 killer and cancer being #2, there have been so many studies with statins that everyone probably knows about, the cholesterol, that actually almost fooled people that when you reduce cardiovascular disease, it almost looked like cancer was being raised. But this is all just the epidemiology, because they're both so prevalent. And to be able to take cancer and heart and combine it to a program like Cardio-Oncology here is very special to all of us. And we're so grateful for everyone to log in here and continue being engaged. Stay tuned for periodic updates with advances at our Heart Institute. We want to thank all the patients, the families that are so generous to share their stories and come out there and share how they've been a really great Sophia for Banner. And our pledge to you is to make sure that we continue to involve the community. If we don't at University of Medicine continue elevating the standards of care and improving the patient experience through truly integrated, specialized medicine, then we're not fulfilling our own journey and our mission. So thank you very much for joining us. Stay tuned, and please reach out to any of us. We would love to get more champions behind this cardio-oncology clinic as we keep going forward. And thank you very much to Banner Health Foundation for sponsoring this event, creating this event, our AV visuals here in the basement of Banner University Medical Center in Phoenix. Thank you very much and have a great night.